Good morning, everyone. Thank you for coming. My name is Justin, as you know, and today I'm here to deliver an education session on distributive shock secondary to anaphylaxis and how this should be assessed and managed. So recently I've noticed a bit of a paucity of knowledge surrounding this topic. So today I want to talk about it. Distributive shock is something we don't focus much on in the pre-hospital setting, and it doesn't really come across our minds. We're more focused on the actual presenting issues like anaphylaxis. However, we need to identify this and manage it in the pre-hospital setting, as this is important for best patient outcomes. So for this presentation, we're going to review the pathophysiology, the clinical features, the important physical examinations, and investigations. After we've discussed this, we're going to go through updated and best practice pharmacological management, decisions to be made surrounding the transport of these patients, and the leadership roles and crew resource management when caring for these patients. Due to our limited time, let's hold the questions until the end. So, let's get started, shall we? Today we're going to start with a review of the pathophysiology. Now, I'm sure you'll all be aware of this, but let's go through it again. Understanding this pathophysiology is vital for us on road, as it helps guide our assessment and management decision making. So distributive shock is one of the 4 different classes of shock, which leads to poor perfusion of tissue. Unique to distributive shock, fluid also leaks out of the vascular space due to the increased capillary permeability, which makes managing these patients even more difficult. Distributive shock is seen in anaphylaxis, sepsis, and adrenal crisis, but we'll focus on the anaphylaxis. In anaphylaxis, distributive shock is caused by a decrease in systemic vascular resistance, which is triggered by inflammatory mediator release. Now that we understand distributive shock, it's important that we also understand the pathophysiology of anaphylaxis. So let's go through that as well. I've got a little diagram here. As I talk through the pathophysiology, I'd like you to go through and put what I'm saying into the diagram. As we know, in anaphylaxis, when an antigen is first introduced into the host, IgE receptor antibodies are produced. This is done when antigen-presenting cells recognize a foreign substance and employs the T helper cells. These helper T cells, through genetic inheritance, are geared up to respond to this foreign substance. And for today's purpose, we're going to make this foreign substance almond. When these T cells identify the substance, the B cells are then called in to produce the antibodies. I know some of you may find this complex. I do myself, but stick with me and we'll get through it. When the B cells ingest a small amount of the triggering substance, this substance is placed on the outside wall of the B cell. The helper T cells then recognize the foreign substance on the B cell and then instructs the B cell to produce the IgE antibodies. In the diagram, the IgE is the little Y-shaped structures you can see. As I've mentioned, the antibodies produced are specific and only specific to the substance ingested or exposed to. The IgE antibodies are then released into the bloodstream and are then fixed onto the mast cells and basophils. These mast cells are generally found in the tissues of the body, whilst basophils are found in the circulatory system and the bloodstream. The IgE antibodies are then fixed onto the mast cells and basophils and are left there for recognition on the next ingestion or exposure of the substance. When this next ingestion or exposure occurs, this is when the trouble starts. The antigen now binds to these mast cells and basophils, that are on the lookout for this substance. When it is recognized, degranulation of these basophils and mast cells occur. It is this degranulation of mast cells and basophils that release inflammatory mediators into the bloodstream. These mediators include cytokines, histamine, and prostaglandins. Mainly, the release of histamine into the bloodstream is responsible for the vasodilation, bronchospasm, and increased capillary permeability that we see. In the case of anaphylaxis, the vasodilation and capillary permeability is the reason distributive shock occurs. So the clinical features of distributive shock go hand in hand with those of anaphylaxis. The common clinical features of distributive shock include altered level of consciousness or altered mental status, tachycardia, tachypnea, hypotension, decreased SpO2, and shortness of breath. You can also develop a cough and a fever. Another interesting but usually not relevant sign in the pre-hospital environment is decreased urine output. Whilst these features are consistent with the signs of other forms of shock, these signs and symptoms, along with a patient history of exposure to an allergen, should be enough to indicate to you that the patient is likely experiencing distributive shock secondary to anaphylaxis. Other signs and symptoms of anaphylaxis, such as urticaria, angioedema, or coughing, can indicate a likely anaphylaxis, and when presenting in the same patient with the signs listed above, will likely mean the patient has distributive shock, likely secondary to anaphylaxis, as we keep going on about. So now we know what to look for. How do we find it? You're right, we do a physical examination. To identify the signs of distributive shock, it is important to take regular blood pressure, SpO2, heart rate, and respiratory rates. It is also important to maintain 4-lead ECG monitoring throughout to monitor for any worsening tachycardia, end-stage bradycardia, and keep an eye on any changes to the perfusion status. Although monitoring the blood pressure and heart rate of the patient will give an indication of the patient's perfusion status, best practice suggests that the patient's mean arterial blood pressure, or MAP, needs to be monitored. A mean arterial pressure of less than 60 millimeters of mercury indicates an adequate perfusion to the heart, kidneys, and cerebral tissue. As you can see, the mean arterial pressure is found or calculated by the diastolic blood pressure, which is plus 1/3 of the systolic blood pressure minus the diastolic blood pressure. I know you may find that difficult, but on our monitors, it will calculate the MAP for you when you do a non-invasive blood pressure, and it is displayed in brackets underneath this blood pressure. It's also important to perform regular chest auscultation on these patients, as wheezes may be present due to the bronchospasm induced by the exposure to the allergen. Furthermore, best practice also indicates that we should be doing chest auscultation on any patient that we give fluids to, as it is a good way to monitor for any sign of fluid overload. So let's move on and let's talk about how we're going to manage these patients now in terms of pharmacology. Remember, we need to treat both the anaphylaxis, which will help treat, which is ultimately what we need to treat the distributive shock. In the case of anaphylaxis, early administration of intramuscular adrenaline is key. Intramuscular adrenaline is used for the alpha-1 receptor effects of this drug. These effects work to vasoconstrict and reverse the vasodilatory effects of the histamine release. In line with your clinical pharmacological guidelines, this can be repeated twice with a dosage of 500 micrograms per administration. This needs to be the focus of initial treatment, as delayed administration of adrenaline is associated with higher mortality rates. Fluids are also a very important aspect in managing these patients. Due to the massive vasodilation and increased capillary permeability, large amounts of fluid can shift from the intravascular to the extracellular space. This can be in the number of 35% of vascular fluid shifted. In patients who do not respond to the initial first dose of intramuscular adrenaline, fluids need to be initiated. Aggressive administration of 20 mL per kilo normal saline needs to be done. In our service, normal saline is used over other forms of fluids such as lactated ringers, as these are shown to have the potential to worsen the patient's condition by creating a metabolic alkalosis. Like we've mentioned, it is very important to maintain and monitor for any sign of fluid overload, especially in the elderly. If this is not effective and continual signs and symptoms of distributive shock continue to occur, vasopressors need to be started. The use of vasopressors is ideal as they create further vasoconstriction and increased cardiac contractility. This increased vasoconstriction causes an increased systemic vascular resistance, which treats the decrease in systemic vascular resistance seen in anaphylactic distributive shock. Increased systemic vascular resistance means increased mean arterial pressure occurs, which means increased perfusion to the tissue and organs. The use of these vasopressors is ideal in the distributive shock patient, as the effects of vasopressors reverse the vasodilatory effects of the inflammatory mediators like histamine. An adrenaline infusion is used as the vasopressor of our service. 1 milligram of 1 in 1,000 adrenaline needs to be inserted into a 500 ml bag of normal saline. Using a burette, 2 micrograms a minute should be started IV and titrated to effect. Now I hear you thinking about antihistamines and that we should be administering antihistamines to these patients. And it sounds right. You think we should be. They've got a histamine release. We need to give them the we need to give them an antihistamine. But the current literature actually de-emphasizes the importance of this. Antihistamine administration in these patients with distributive shock is more of a nicety rather than a need. These medications are known not to treat the hypotension or increased capillary permeability seen. It's also known to not inhibit the release of inflammatory mediators from the mast cells or basophils, and multiple randomized control trials actually failed to show any benefit of antihistamine administration in the anaphylactic patient. However, antihistamine administration may be beneficial in terms of managing the patient's subjective symptoms such as itch and scratchy throat, which in turn may make a more compliant patient to manage. Although this is not something we need to focus on, early and aggressive management with adrenaline should be the main focus, and it should not be delayed for the administration of an antihistamine. It's for this reason we don't give antihistamines in our service, as we want to reduce the cognitive load of our paramedics. So let's think about some other relevant investigations. Apart from the normal vital signs being monitored during the care and treatment of this patient, there's not really many other investigations for us to do in the pre-hospital setting. A 12-lead ECG should absolutely be attained, and this is to ensure there are no ischemic changes from severe tachycardia that may be present. We also want to make sure that there's no mimickers of cardiac conditions that may mimic the hypotension or other signs of distributive shock. A measurement of lactate is also used to indicate shock. The measurement of lactate is actually used to indicate the body's endogenous adrenaline release in response to a physiological stressor. A high lactate of greater than 4 millimoles is something to be concerned about, although it should not take up all your focus. It's not to be relied upon, as these patients can also present with a normal lactate. And as we know, a high lactate is a measurement with a large range of differential diagnoses. So, now that we've identified the condition, we've stabilized this patient on scene or en route, how and where are we going to take this patient to? So these patients require urgent definitive care at the hospital. The most appropriate destination for these patients is the closest available hospital. All emergency departments have the ability to manage these patients. On arrival to the hospital, these patients will be assessed and managed with further doses of adrenaline and further airway management should they require. It is important that the intensive care paramedic on scene travels with this patient, as these patients may require further and more advanced pharmacological management and skill than advanced life support paramedics can administer. Whilst it is important to stabilize and perform all the relevant investigations for these patients, it is important that these tasks do not delay early rapid transport. All attempts should be made to load the patient as soon as practical, and the focus is doing as many assessments and starting as much management en route. Depending on the clinical picture of the patient and the patient's response to any treatment, these patients should be transported under road speed, as it's the most safest thing for us. However, if we need to go priority 1 to hospital because the patient is deteriorating further or not improving, we can do that. It's important to remember to pre-alert the hospital of your impending arrival so there's no delay in offload, and we can make sure the patient receives timely care once arriving to the hospital. So let's talk about the leadership and crew resource now. Crew resource management. With these patients likely requiring 2 crews on scene, it's important to have a clear leadership structure. Despite the intensive care paramedic being the most clinically senior officer on scene, this does not necessarily mean they need to be in charge. It is most important to have this intensive care paramedic available to utilize the skills and pharmacology they have, and it may prove difficult if they're hands-on buried in a task or they're hands-off running a job. So having clearly identified roles on scene is crucial for the successful patient outcome. Having each paramedic on scene with a clearly identified role is also important for smooth patient care and to ensure no points of care are missed. A paramedic should be placed on each of the following points of care, being team leader, airway, access and drugs, and runner. It is important the team leader utilizes the most appropriate leadership style. In these patients, a democratic approach is indicated. However, it is important that the leader is still identified. With democratic leadership, tasks are allocated to members of the team, and these team members are entrusted to complete the task in their entirety and independently. Furthermore, feedback from the team member is sought from the team leader when a task is completed or problems are encountered. This also ensures clear communication throughout the team and whilst on the job. So with everything we've discussed today, you should be well prepared to treat any patient with distributive shock secondary to anaphylaxis that you see. To summarize, we've covered the important aspects of identifying the shock from the pathophysiology, the presenting clinical features, and the physical examination. After we identified the cause, we've discussed how to treat it. We've also identified the required pharmacology, transport decisions, and required leadership roles. I'd like to thank you all for attending this quick little session today. If you have any questions or comments, please reach out and don't forget to mark this down for some CPD. Thanks very much.